So I would say we are facing really exciting times in the treatment of non-small cell lung cancer. We have oversight a lot of changes during the last 5 years, I could say. And probably there are two major changes. One is the identification of driver-driven tumors. It means those tumors, non-small cell lung cancer tumors, that harbor EGFR, AL, and TRK, ROR, RET mutation that can be treated with targeted therapies. And the other group of patients are those that can be treated with immune therapy. So I would say immune therapy and targeted therapy and big two apples of the advanced non-small cell lung cancer treatment now. But we have a lot of challenges right now. We are facing challenges. So when do we have to treat these patients with combinations of chemotherapy and immune therapy? Other challenges are whether we have to choose or select or use other biomarkers such as TMB for the treatment with immune therapy. And we have had really nice data presented in this meeting in which there are new insights about the role of TMB in patients treated with immune therapy. So we thought till now that immune therapy TMB was not the ideal biomarker to select patients to be treated with combinations of immune therapy, double combination with immune therapy. But yesterday presented the data on the Keynote 1 for 7 trial in which they demonstrated that TMB indeed has a role in identifying patients who can achieve higher benefit of being treated with immune therapy beyond PD-L1. So this is important data. So we are going to have a lot of new data presented in this meeting also. I would say in the field of targeted therapies, we are going to have the final overall survival data for the FLAURA trial. This is very important because we have had several trials comparing different generations of tyrosine kinase inhibitors. Until now, we have had no clear evidence that the treatment with new generation can improve overall survival for these patients, and that's why we are also practicing using sequencing approaches. But today, it's a big start, plenary session. We will know if using new generation tyrosine kinase inhibitors, osimertinib, can meaningfully improve overall survival for patients with EGFR mutations. What else? We will have also data about the Checkmate 227 trial, which is comparing the use of double immunotherapy over chemotherapy alone, and we will have overall survival data. So this is first time we will have final overall survival data exploring double combination immune therapy instead of single agent or chemo plus immunotherapy. So I think this is going to be also a start for this meeting. What else? Targeted therapies, developmental. We are moving really fast. We are going to have a lot of presentations about new NTRK inhibitors. NTRK is tumor agnostic biomarker, which is very important. We know that in advanced non-small cell lung cancer, we have NTRK positive tumors. So this is great success of the activity of these specific targeted inhibitors of NTRK. And very important, we have in the developmental therapeutic sessions today, we have updated data on a new KRAS inhibitor, which is AMG 510. This is very important because KRAS group of patients, which is the most important group of patients with advanced non-small cell lung cancer patients, they do not have any option for targeted therapy. So I think it will be very nice to see which is the activity of this specific target inhibitor in KRAS. I could say for other tumors, because it's not just non-small cell lung cancer, we also will have data on the activity of pembrolizumab in mesothelioma patients, which I think also can change, well, let's see if can change the standard of care for these patients in which we are in need of different therapies approaches for the second line setting. So mutations in the EGFR receptor are quite common, but not only in the EGFR, but I would say in the all ERB family of receptors, which is quite different. So in squamous cell lung cancer, you can have alterations in EGFR, ER2, ER3, and ER4. And beyond mutations, you can have other alterations such as overexpression or amplification of these genes. So it's a pathway that is quite highly activated in squamous cell lung cancer. However, in squamous cell lung cancer, as there's not indication of any targeted therapy, we are not used to do any next generation sequencing as we are doing for non-squamous advanced non-small cell lung cancer. So I think we are in need of further exploring all the genetic alterations behind this squamous non-small cell lung cancer disease. So this is important because there are some data, exploratory data, that suggests that there might be activity of specific targeted kinase inhibitors such as afatinib in this group of patients with squamous cell lung cancer, advanced squamous cell lung cancer. And indeed, in the trial explore comparing erlotinib versus afatinib in the second-line setting, they demonstrate that those patients with squamous cell lung cancer that had shown a longer benefit from the treatment with afatinib were those patients that had a higher rate of epidermal growth factor, well, ERB2 mutations or ERB2 mutations and ERB family of mutations. So I think this is important because it opens new possibilities to explore these alterations in the treatment of squamous cell lung cancer. And it's very important because as immune therapy has moved to the first-line setting, now we are in higher need of more options of treatment for the second-line setting. So afatinib remains really logical option for treatment in the second-line setting for these patients. So the evidence to use tyrosine kinase inhibitors in squamous cell lung cancer, advanced squamous cell lung cancer, is based on an exploratory analysis of LAXLAN 8 trial, which compare afatinib versus erlotinib in the second-line setting of advanced non-small cell lung cancer patients. This trial demonstrated that afatinib significantly improved the outcomes, overall survival and progression-free survival over erlotinib in patients with squamous cell lung cancer. So it's a potential option to use in the second-line setting. So what they did, they observed that there were a group of patients, around 20% of patients, that achieved long-term benefit from the treatment with afatinib. So when they explored this patient and analyzed with NGS, the status, genetic status, a comprehensive genetic study of these patients, what they observed was those patients that had longer benefit of the treatment with afatinib were those that harbor alterations in the ERB family of receptors. That means not only EGFR, but also ER2, ER3, and ER4. However, there is more data that supports the use of afatinib in patients with ER2 mutations. There was also performed an exploratory analysis of the compassionate use of afatinib in patients with advanced non-small cell lung cancer patients. And what they observed, they analyzed also those patients with, which had most benefit from the treatment. And they observed that those patients with ER2 mutations, most commonly insertions in ER2, were those that achieve higher response rate and higher benefit from the treatment. However, we are in need of performing prospective trials to validate this. So those are exploratory analyses that provides a good signal that there might be a higher activity in those patients with alterations in the ERB family of receptors treated with afatinib, but it could be important to do a prospective treatment for further validation. has not been deeply studied because the use of tyrosine kinase inhibitors in squamous cell lung cancer is not widely used. For example, in some countries in Europe, we can not use afatinib for patients with squamous cell lung cancer. And I think it's a really good question. I mean, probably I could say that these patients with squamous cell lung cancer treated with tyrosine kinase inhibitors that demonstrate higher benefit from the treatment, probably when they progress, it could be very nice to take biopsies and to study which mechanisms of resistance they have. However, it's very difficult to say if those mechanisms are going to be the same that the mechanism that we are used to seeing patients with non-squamous, non-small cell lung cancer. Well, so unfortunately, we do not have data about this. And we do not also have data on how to overcome this resistance. From my presentation, I could say, well, that tyrosine kinase inhibitors are an option. Afatinib, it's an option for patients with squamous cell lung cancer, and we have to keep them in mind because we are using immune therapy, chemotherapy in the front line. So in the second line setting, we are in need of further treatment. So is there, and I could say also that we have to start thinking about using NGS not only for non-squamous cell lung cancer, so probably for squamous cell lung cancer, not only to identify these alterations, but there are other predictive biomarkers of immune therapy, such as STAC11, that is there. So I think it could be good to start doing NGS for squamous cell lung cancer to have higher knowledge about their molecular background and how do they behave with the different treatments we are doing in the first line setting. All the other messages, immunotherapy, it's important, it's there. We have to think about immunotherapy in almost all settings, except for those patients with contraindications, for the patients with alteration driver mutations, and for those patients with bad performance status. I would say those are the only exceptions for giving immunotherapy in the first line setting. And the final message could be, well, whether you are using immunotherapy alone or immunotherapy with chemotherapy in the frontline setting, the important message is immune therapy, either in combination or single agent, improve the outcomes in terms of overall survival and progression-free survival.